Welcome everyone. For this session, we're going to be talking about the whole body approach to stroke care. Our first speaker is Dr. John Volpi. Dr. Volpi is the Vice Chair of Clinical Services for the Houston Methodist Hospital, Department of Neurology. He's also the Elkins Family Distinguished Centennial Clinical Academic Scholar in Neurology and also the Director of our Eddie Skurlock Stroke Center. With years of clinical and research experience, Dr. Volpi has been a mentor for many medical students, residents, fellows, nurse practitioners, and physicians, including myself. He's here today to discuss the brain-heart connection. Dr. Volpi.
Thank you, Dr. Garg. It's a pleasure to be able to share this presentation and this time with you all. I think that, as vascular neurologists, we often see our patient with a stroke and start looking for a culprit. And as we look, we're often implicating our colleagues in cardiology that their organ, the heart, is the cause. And I want to take a step back and really show how, as a vascular neurologists and neurologists, we can kind of own this discussion as well and cooperate with our cardiologists in terms of finding the source of a stroke when we're suspecting a cardioembolic etiology. So what I'll be talking about is really that part to start off with, diagnosing the cardiac etiology in the two most common scenarios that we encounter, arrhythmias and patent foramen ovale, or PFO. But then to take one step back and think a little bit about whether this is really a causal relationship and when it's an effect relationship and not a causal relationship, and think about how stroke affects the heart and not just how the heart affects the brain. So let's talk about diagnosing embolic stroke. This is the term that we've adopted, an ESIS among us, maybe, embolic stroke of unknown source. And an embolic source of unknown source could also be called a UFO. It was an unidentified flying object in the circulation. What would lead one to think that a patient has an ESIS event is that they don't have maybe the typical atherosclerotic risk factors. Every one of these things, hypertension, hyperlipidemia, diabetes, smoking, they are a dose effect. So if you're encountering a patient who's older, who's had years of hypertension, untreated hyperlipidemia, poorly controlled diabetes, all of that would lead to vessel narrowing and atherosclerosis. But if you're encountering a patient at any age that doesn't have that dose effect, you might wonder whether the stroke was in fact of an embolic etiology. And then when we think of those non-atherosclerotic strokes, embolic events are the leading cause. But it's important to take a careful evaluation. It may be of unknown cause, and we simply never find it and call it cryptogenic. It may be AFib, or it may be PFO related. So this is a way of looking at what is commonly thought in many patients. What if it's AFib? What if it's a atrial fibrillation? And of course, if the patient walks in and has an EKG in the ER that shows atrial fibrillation, the deal is done. You know that's the cause. But the question that this study asked is, what if the patient didn't have AFib detected? So it was a cryptogenic stroke at the time of discharge from the hospital, and they were looking for hidden or occult atrial fibrillation over a time period. And they did that using an implantable loop recorder. So this is the Crystal AF study. And I'm showing what is often, maybe overlooked in our clinical trials, and that's just the baseline demographics. This is the Table 1 data from the Crystal AF study shown there in the second column. And I'm comparing that to a different cryptogenic stroke population, the REDUCE trial. So the REDUCE trial was looking at patients who were thought to have less risk factors, being somewhat younger and not having as many of the typical risk factors there of diabetes, hypertension, smoking, and as a result may have less likelihood to have atrial fibrillation and maybe more likelihood to have PFO. So the first point I'm just making is that when looking at a cryptogenic stroke, they really are not the same data sets. So if you're thinking about using a loop recorder, your patient should resemble the Crystal AF if you're going to cite that data as being important for your decision making. And similarly, if you're thinking about PFO closure, your patient should resemble the patients who are in REDUCE without the risk factors. Keep in mind that the incidence of atrial fibrillation in the population of patients between 50 and 59 is low, less than 1%, and it gets lower as one goes down on the age range. So if we move from the Crystal AF study, in which we were looking for AFib in a patient population in which we weren't sure, there was a stroke, but we didn't know where it came from, we can even turn the question the other way and say, what if we find a large vessel stroke or a small vessel stroke, that kind of lacunar infarct, or a patient has carotid stenosis in which we really think we know what caused the stroke? Well, it turned out when we didn't know in the Crystal AF study, we found AFib about 10 to 12% per year. So would we expect to find the same in a patient population in which we did know the cause of stroke? Well, the answer was yes. It was almost identical between the two curves of the patients in whom there was an unknown cause of stroke and a known cause of stroke. So that's what I'm showing here on the stroke AF, is the patients who had the known cause. What's very interesting to me is that what time frame do you want to do your monitoring? Well, in the stroke AF, it was the patients who had an implantable loop recorder would be monitored for years, maybe up to 3 years. But if we look at what was detected, the clinical events that separated the two patients were primarily in the first 30 days. So if you're a naysayer, if you don't see maybe this is a call to action, the reason would be that the clinical events that you would detect and change management were primarily occurring within the first 30 days. But clinical events are not necessarily the same as changing management for prevention. So a number of the patients were detected beyond 30 days. Again, so if we go past this point and we look at how many events are detected beyond 30 days, it's about the same. So again, if you are on the other side of the argument and you're arguing for long-term monitoring, your argument would be that you find just as much AFib in days 30 to 60 as you found in days 0 to 30. So it remains an important discussion to have with your patient, with your cardiologist, about the importance of long-term monitoring and in whom you should select. So the reason we're doing the lecture today is to kind of give clinically relevant information to your practice. So how do I actually practice in 2022? Well, I would give a loop recorder to a patient who's over 60. They resemble those patients in Crystal AF, and I would consider it also for the patients who have multiple risk factors, even if they're under 60. And then I would also pay attention to an echocardiogram. A patient who has an abnormal left atrium is a arrhythmogenic left atrium, and a left atrium that's sick and more likely to have AFib, and I would recommend it for those patients as well. But if the patient is under 60, if they're 59 and under without typical risk factors, I would not recommend a loop recorder at this time. Or even if the patient's over 60 and they have a normal echo, a normal EKG, and they don't have a family history, and I may just add they don't have a history of high alcohol intake. We know that that also is a marker for paroxysmal atrial fibrillation. So moving beyond AFib and looking at the PFO is the other common cause in our patient population for stroke-related emboli. Is TEE the best tool for detecting PFO? How can we have this conversation? So looking back, if you like the Wizard of Oz, do you only need a heart or do you only need a brain in terms of finding the diagnosis? Well, these are your detection options. If you only need a heart, you're looking at a transthoracic echo with a bubble Doppler or transesophageal echo with a bubble Doppler. But if you only need a brain, you're looking at the transcranial Doppler. In this case, you have the probe on the temple, and you listen as the bubble study is done to see if the bubbles are shunted from the venous circulation to the middle cerebral artery as a way of detecting a right to left shunt. At that point, you can't be certain that it's a patent foramen ovale, but it certainly suggests that. Other detection options include a cardiac MRI, and the gold standard would be the catheter-based intracardiac echo. So what do we know about these protocols? Even if you know nothing about TCD, even if this is the first time you've seen a TCD, you can see very clearly that there's a smattering in the very middle of these white signal, and that's the bubbles. So if you were infusing bubbles into the vein, you would actually hear on the patient receiving the test, blip, 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 and that would be very clear that it was a positive study. So it's not a difficult study to interpret. It's a very easy detection. What about transthoracic echo? Well, I'll be the first to say I'm not an echocardiographer, but the view from the transthoracic echo is from the chest wall, and the left atrium is rotated posteriorly. So in this view, the left atrium is furthest from the probe. So if you want to change that up, you want the probe to go down the esophagus. So this is the transesophageal echo, showing the left atrium closest to the probe. And that would be commonly used for looking for PFO if it's positive with the bubbles within the first 3 cardiac cycles. So if the intracardiac echo is the gold standard, and we could argue whether TEE is the gold standard, this is a study that compared TEE to CD and transthoracic echocardiography. And I won't go through every number, but I'll just point out that what you're looking for with a patient in front of you is you don't want a false negative. A false positive is acceptable in a screening test. And in this case, all the patients who were TE positive were also TCD positive, and all the patients who were TCD negative were TE negative. So it was a high negative predictive value for a transcranial Doppler, but there were false positives where the TCD was positive and the TE was negative. And that's just stating that, and also pointing out, for what it's worth, that TCD is less costly and less invasive. What about cardiac MRI? It's not sensitive in all cases for PFO. Of course, the patient has to sometimes do provocative maneuvers like a Valsalva, and depending on your patient's cooperation, level of sedation, that may be limiting. It is non-invasive, so that gives it some advantage over TEE. And compared to the cost of TE, at least through most payers, it is about the same cost for a cardiac MRI. And the gold standard remains intracardiac echo. Unfortunately, it requires the most invasive procedure, right heart catheterization. It's rarely used as a diagnostic modality, but this is the modality you would use if you have conflicting results. If you have a TCD that might be positive, a TE that's negative, and you're deciding whether or not to treat the patient, you're prepared to treat, but you're using the intracardiac echo to in fact demonstrate the PFO before placing a device. So in conclusion, for PFO detection, TCD as a screening tool for PFO evaluation is the most sensitive and should be first line for screening. I'll say stay tuned. If you're interested in the International Stroke Conference, an ongoing national study of robotic TCD will transform the field, and that's all I can say in that regard. And I'll also say that we usually proceed with TE in our practice only if a patient is considered a candidate for closure. I'll conclude with a statement in this section from my colleague Dr. Mark Rubin, who said a patient is not PFO negative until the TCD is negative. So I think that's an important way of viewing PFO. So moving past the diagnosis and into the question of cause and effect, we talked about the Crystal AF study earlier, and it showed a curve, and I was kind of pointing out how the curve was important for clinical decision making for diagnosis. But I want to point out one other thing about the curve, and that's how the curve has this slope early on that's fairly steep, and then a different inflection point after that. So the second linear slope comes in after about 90 days and suggests a different event. So it's no longer that steep slope, so something else is occurring that's more likely an effect of the stroke at that point. And what might that be? What might that thing be? Well, in this group of patients, again, they're stroke patients who are over 60. They may simply share risk factors with patients who have AFib. They may have things like obesity, diabetes, smoking, cardiovascular risks, and medications that may be arrhythmogenic, and that may be why we're detecting AFib. And then, quite simply, aging. When we're seeing this trend, this linear effect, it's occurring over 3 years, so we may be detecting more AFib because the patients are getting older. But if that's the case, the linear portion of the curve is predicting a 10% annual incidence of AFib. If we look only at the age effect, that would predict just 2% of that 10%. So if we're talking about 360 and a true 360 event today, we need to think about the neurological injury maybe affecting the autonomic control of the heart. We know autonomic dysfunction is observed in about 40% of patients with stroke. We see the spikes in blood pressure, the drops in blood pressures. But we also can see, if we look from the heart perspective, that atrial sites, which account for 90% of the AFib, derive from a common embryological origin and share a high sensitivity to autonomic neurotransmitters compared to other atrial tissues. So something about the stress, the dysautonomia can particularly be harmful to these atrial tissue that promote AFib. What else may promote AFib after a stroke? It may be that the patient has a cranial nerve dysfunction. We can hear dysarthria, but we know there's also pharyngeal muscles that are weak, and that may lead to sleep disordered breathing. Sleep disordered breathing is a known risk factor as well for AFib. And even post-stroke depression, depressive symptoms can contribute to a higher incidence of AFib. So we're left with observations at this point, but also unanswered questions. And what I'm showing here is a PET scan from a completely different field, is epilepsy. And it's showing the parts of the brain where seizure foci have been associated with a high incidence of sudden unexpected death in epilepsy. This has been, over time, correlated that certain brain regions put a patient at higher risk of ventricular arrhythmias. So one wonders whether the volume of a stroke also imparts a higher risk of AFib. Are there hot spots also in stroke patients that are more arrhythmogenic? And do some of our therapies that may be aimed at recovery reduce inflammation and have additional benefits for stroke prevention, such as preventing AFib? So in summary, a proper diagnosis of cardioembolism as a cause of stroke is a cooperative evaluation which depends on the neurological as well as cardiac expertise. Advances in rhythm monitoring are helpful, but should not lead to a one-size-fits-all approach to implantation. And similarly, PFO detection requires high sensitivity testing with TCD in patients with high likelihood of PFO-related embolism. And finally, among patients with stroke, the late effect of the stroke may influence cardiac health through autonomic changes, sleep effects, and mood changes. Thank you very much.
Thank you, Dr. Volpi. Just had a quick question for you. So for patients who you do truly believe are ESIS and you have a high suspicion for maybe cardioembolism, in terms of anticoagulation versus antiplatelet, what do you do in your practice?
Yeah, this is an excellent question about what I guess we can say is just, are you going to take a pragmatic approach, or are you going to take an approach of observation and reaction? You know, are you going to simply put a device or an external monitor and wait for AFib and then start anticoagulation, or should you start a patient on anticoagulation and maybe stop it after 90 days if there is no atrial fibrillation? You know, I think that, of course, it remains an individual decision, but if you were to make me choose, I will choose the anticoagulation on the front end, simply because it's not just about the fact that the detection rate is low, because what we said is we're only going to find it in 10%, so in some ways we're over-treating maybe 90%. So why would I do that? It's because that 10%, the AFib strokes are the worst kind of strokes. They're the bullet to the brain, the 5 times higher disability. So if I'm concerned enough that the patient has AFib, I'm concerned enough that I'm often willing to take that kind of pragmatic approach and put them. The other thing is that, quite simply, our DOACs are now safe. You know, it's not like placing a patient on Coumadin. It's not necessarily committing the patient to lifelong treatment. But being able, we come to work every day to prevent stroke. That's our job, and I certainly will go the extra mile here and put myself a little bit on a limb and say that in a patient who I'm concerned about having a 30 to 90 day anticoagulation run while we're getting that data, I'm comfortable with that.
Thank you.
Yeah, thank you.